Good morning, ladies and gentlemen, and thank you for waiting. Welcome to the REL WebEx conference call. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Jennifer Lundblad. Ms. Lundblad, the floor is yours.
Great. Thank you, Ryan. Good morning. This is Jennifer Lundblad, President and CEO at Stratis Health, and I want to welcome you to this webinar session titled Using Race, Ethnicity, and Language Data to Improve Healthcare Quality. We're really pleased to be offering this session. It's provided through funding from Minnesota Community Measurement as part of a larger effort that is the Aligning Forces for Quality initiative here in Minnesota, funded by the Robert Wood Johnson Foundation. And it's our privilege here at Stratis Health to have put together the training session that not only includes today's webinar, but the previous webinar and the companion piece to this one, which is focused on collecting race, ethnicity, and language data, and the associated in-person training sessions. Here in Minnesota, I think we have much to be proud of in terms of the quality of care we deliver. We tend to rate very highly when comparing ourselves nationally on quality measures, both in the inpatient and outpatient settings and across the continuum of care. However, we all know that if you start to peel those data away, we have some fairly stark disparities in care based on race and ethnicity and socioeconomic status. What we've known to date around that is data that is really at the population level, state or county, for example, and we've had much less information available to us at the practice site or the clinic or the hospital level that would really allow us to take action and improve and try to reduce some of those disparities in care and truly be more responsive to the changing demographics and cultural communities in Minnesota. So the set of activities that is around helping you to collect race, ethnicity, and language data, which I'm going to now refer to as REL, the ability to collect those data and the ability to do something about it, which is really today's focus, are critically important to continuing to deliver the highest quality of care to all of our patients here in Minnesota. So we're really pleased to be offering this session today, which is again focused on how to use the data that you've collected. We're going to be covering three areas, and we hope by the end of the session that you'll be able to list and describe the foundations of quality improvement, describe the PDSA, or Plan, Do, Study, Act cycle, really one of the most commonly used approaches in quality improvement. And then what we'll be spending most of our time on is the third of these objectives for our session today, which is to understand how you can incorporate REL data into your quality improvement work in your practice. So we're going to start with what should be familiar to most of you as the foundations of quality improvement, that being that quality improvement is customer-focused, process-oriented, and data-driven. Customer-focused is the first of those. This is really asking us to look at who are we serving, both internally and externally, who are our customers, and what does it take to make our customers happy and healthy. These seem like fairly straightforward questions, but we all know that healthcare is complex. And while the obvious customer to all of us is our patients, and in some cases their families, whether that's pediatrics or geriatrics, families are often involved, what we also know is that in healthcare, often the patients aren't those that are paying the bills. And so customers also include those that are providing insurance, whether that's commercial insurance or public insurance through Medicare or state public programs. So the question about customer is not nearly so straightforward as it seems. And as part of this session, I would ask you to be thinking about, are you serving all of those customers, in particular your patients, who might be coming from different racial or ethnic communities or cultural backgrounds, in ways that truly can make them happy and healthy? The second foundation of quality improvement is that it's process-oriented. Almost everything we do is a process, and research tells us that 85% of quality problems can be traced back to a process or system issue. And what we know is that well-defined processes reduce variation. I think it's telling if you read the quote at the bottom of this slide, no matter how well equipment is designed, no matter how sensible regulations are, no matter how much humans can excel in their performance, they can never be better than the system that bounds them. We all know that's true, and a quote that we often use in quality improvement is also that the system is perfectly designed to get the outcomes that we get. The foundation of quality improvement is that it's data-driven. And if we ask ourselves, how does measurement help improve quality? It helps us by helping us to understand the variation that exists in a process. It helps us monitor a process over time, particularly as we're looking for improvement in that process, and then to see the effect of a change that we're putting into place and tell us if that has made things better or made things worse. It also provides a common reference point for us and a more accurate basis for making predictions about changes that we want to make or implications for decisions that we have made in our practice. Again, I would ask us to think about being data-driven. What has been to date the data that you've had available to you as it relates to race, ethnicity, and language, and what might you be collecting so that you can have better data available to you going forward in your quality improvement efforts? Again, those three foundations should be a refresher for most of you on the call in terms of the basics for quality improvement, but we wanted to make sure that we were all on the same page as we begin to talk about more specifically how we might use race, ethnicity, and language data. Any of you who are nurses on the phone might find this first line familiar. If it's not documented, it's not done. It simply didn't happen. I think it's a little bit like if a tree falls in the forest, who's there to see it or hear it? And that's a parallel in quality, that is, we can't manage what we don't measure. So again, emphasizing the measurement and the importance of measurement in quality improvement. So now let's shift our attention and focus on, with that as it's our foundation, what might we be able to do and how might we be able to take advantage of having REL data available to us? This session and the next slides that we're going to walk through assume that you as a practice have those data available to you. We know that's generally not true in most practices across Minnesota today, but we hope we're on the verge of a fairly substantial shift and that most practices will in fact start gathering those data. So the assumption here is that you have it in front of you, and again, as I mentioned, there's a companion webinar to this one that is focused on collecting those race, ethnicity, and language data, and there's a handbook specific to the collection of those data. And I'll point you to the Minnesota Community Measurement website, www.mncm.org. If you go there and click on the resources section, the first things that pop up are both the webinar that's about collecting data and a link to the handbook. Both of them are terrific tools that will lead you to the point in time where you, in fact, do have these kind of data available to you to work with. I also want to set the stage a little bit for what the changing expectations are here in Minnesota about having these data and collecting them and reporting them. Beginning in 2009, or the dates of service that are happening right now, medical groups who are participating in the Minnesota Community Measurement Direct Data Submission process will be expected and asked to develop a system to collect and report race, ethnicity, language, country of origin, and insurance coverage data, insurance coverage being a proxy for socioeconomic status. These data elements will be combined with or married with clinical data that you are probably already reporting and submitted through the direct data submission process. This collection of race, ethnicity, country of origin, and insurance coverage will be voluntary in 2010 for dates of service in 2009. And then if you choose to participate in the community measurement direct data submission process going forward starting in 2011, it will be required. That will be for dates of service in 2010. We also anticipate that as part of the health reform work at the state, that there will soon be some sort of requirement also that it will be part of a state mandate that will include race, ethnicity, and language data. It's not currently part of those rules and regulations that are out for public comment, but that's certainly been part of the discussion. So we're in a changing environment where we have recognized as a state and as a community just how important it is to have these data available to us and to have them available to us at a fairly granular level, meaning at the practice or medical group site. And so we can anticipate that there will be a growing interest, demand, and perhaps eventually a mandate for including collection of these sorts of data elements when you're collecting clinical data for public reporting. This next slide shows some of the categories of data collection, and again, I would point you to both the webinar and the handbook that's been developed around collection of data. What will be collected is in race and ethnicity. You can see the categories there: American Indian or Alaska Native, Asian, Black or African American, Hispanic or Latino, Native Hawaiian or other Pacific Islander, white, and then you will also have the option of declined or unknown. In the language area, there are about 30 different options available to select from in terms of preference for language. That can be language spoken by the patient at home. It can be the language that they prefer to receive written materials in, and there's also some sections around health literacy or English language proficiency. So again, about 30 different categories under language. Country of origin, there are about 200 countries listed. Again, those are all part of the handbook and were discussed in the companion webinar to this one. And insurance coverage will ask a variety of options that fall into a number of different buckets that are commercial insurance, Medicare, Minnesota healthcare or state public programs here in our state, whether someone's duly eligible for both Medicare and Medicaid, whether they're uninsured or whether they are a self-paying patient. So again, that gives you a flavor of the kinds of things that you will be asked to start collecting if you're not already. So once you have that in hand, that's when you have the opportunities to do something different that, again, will improve the quality of care for your changing patient population and be responsive to what you might learn from these data as it relates to race, ethnicity, country of origin, language, other types of things that help you understand better who your patient population is and what you might need and want to do differently. So what we're looking at here are hypothetical but realistic data from a clinic that shows you, once you start to look at the composition of your patient population, how you might understand and begin to take some action. So this just looks at the race ethnicity question. Again, we're looking at 1 quarter's worth of hypothetical data. In this clinic, they saw just over 4,000 patients. No surprise, predominantly a white population, 67%. We've also chosen to put these data in a bar graph so that, again, sometimes it's helpful to visually see some of the distinctions. This points out again just how predominant the white population is. But it also tells us that the second largest population is the African American population, and the smallest one is the American Indian population. So often we think we might just want to stop there. We've collected race and ethnicity data. Isn't that enough to know? But if you think about it, there's a whole lot that we don't know, even when we have these data in front of us. And I'm going to give you 3 examples of what we don't know, even though we have the race and ethnicity data. So in this hypothetical clinic, we know we have a large Eastern European or Russian population that has some pretty special health care needs. That gets masked by the category white. You can't tell in looking at that large group, 67% of this clinic's patient population, that there is in fact a subgroup within that is Eastern European that has some different language needs and probably has some different clinical needs, things that show up with a higher degree of prevalence or incidence in that particular population. So again, race, ethnicity data alone don't tell us and often mask information that would be really helpful in planning and improving the quality of care that we deliver. Another example, African Americans, those that are born and native to this country, and African immigrants, those who have arrived more recently, often have very different cultural needs. How can we understand what we want to do within that second largest group in this clinic, the group that is categorized here as Black or African American? It really doesn't tell us those that are native born, those are African American, and those that might more recently have come from Somalia or Ethiopia. Third, we have a sense that American Indians make up a larger part of our overall community. How does this very small percentage that are showing up as a part of our patient population compare to the sense that we have that in our community there are more American Indian or Native Americans? How do we understand that? What these 3 examples point out are just the limitations of looking at race and ethnicity data only, and the importance of looking at the whole, more comprehensive package of data that you'll be asked to collect, and hopefully maybe have begun to take some steps in that direction. So now say that we've added country of origin to, in addition to collecting the race and ethnicity data. It begins to tell us, if we look, for example, at the Black and African American population, that of the 679 that made up that larger category of Black and African American, 71% of them are of country of origin is the United States. But look at the next two lines. Pretty telling that we have a large group of Somali and Ethiopia patients that we're serving. What does that tell us that we need and want to be doing differently in terms of how we are designing and implementing the services that we provide, and what kinds of quality improvement projects might be called for once we have that information in front of us? Again, trying to display these things in graphical format often helps reveal some areas that we might want to focus on. So if you think about what REL data would be helpful when you're planning a QI initiative, I hope that these examples have indicated to us that it's not only the race and ethnicity of all the patients, but really the country of origin. You might choose to look at what are the top 5 if you're in an area where there are many different immigrant and cultural communities, or you might choose to focus on one if your clinic has a particular group that has grown in recent years, or you know that makes up a large portion of your patient population. You also want to look at the primary languages of all patients. Again, could look at the top 5 or could focus on one in particular. Insurance coverage, a poor proxy, some might argue, but it is a proxy for socioeconomic status, and we know that's also important as we're trying to design and improve the quality of care that we deliver. And then linking all those data with the specific healthcare needs. If you look at your registry and you look at all your patients with diabetes, and then you look at race, ethnicity, and country of origin, does that tell you something about where there might be some gaps in care, where there might be some disparities, where there might be some opportunities for improvement? Then, of course, we know that you're all focusing on improving quality of care in a whole variety of areas. These are very typical examples, and those 3 that are highlighted and asterisk for you, depression, diabetes, and vascular disease, are the areas that in the Minnesota Community Measurement process for direct data submission will then be linked to the REL data that you'll be collecting and providing. But let's focus on diabetes for a moment. That's certainly a condition that affects many of the patient populations that we're serving. And what we have done in recent years here in Minnesota is focus on what we've called the D5, 5 elements of diabetes care that we know in combination can really improve a patient's quality of life and quality of care that they have. And I want to focus specifically on blood pressure less than 130/80. That's a particularly critical indicator among this D5 package, or the composite or all or none measure of diabetes care. With the data that you will hopefully soon have available to you at your clinic or at your medical group, you could then take the breakdown that you've chosen to focus on, in this case diabetes, and take the elements of the D5 and look across the different racial and ethnic groups and cultural communities that you are serving and hone in on places where there might be some real needs or some real opportunities for improvement. So I know this slide's a little bit small, but we're going to use the example of the African American community and maintaining blood pressure of less than 130/80. And what we see here is that for the African American population, 45% have that blood pressure level maintained or are in compliance, compared with the white population of 64% and an overall level of 59%. So we know that that's a pretty big gap, and that might be where we want to focus some energies in terms of a quality improvement initiative. So the first steps in this or any quality improvement initiative are really laying the groundwork for success. These, again, should be kind of repeat refresher items for any of you who have led or been part of quality improvement work in the past or currently in the roles that you have. We know how critically important leadership support is to to be able to have the time and the resources and the commitment from leadership to focus on improving a particular aspect of the practice or the care that you deliver. We know how important it is to align quality improvement efforts with broader organizational goals or priorities or strategic objectives. A quality improvement project can't feel like it's out in left field. It needs to feel like it's aligned with and supporting where the clinic or practice wants to go. It's also important to make sure that quality improvement work really aligns with staff interest and accountabilities around those improvement efforts so that, again, it lead to success and that those changes will be sustainable. And then where we're all resource constrained around time and capacity, making sure that you have those even in this resource constrained environment. And then understanding the process that you currently have in place that might have room for improvement. So what we're going to do now is walk through the model for improvement. This, again, should be familiar territory for many of you who have worked with quality improvement initiatives in the past. The model for improvement is a widely accepted approach for quality improvement work. The visual model lays it out quite nicely. It's built around three basic questions that we'll talk about in just a moment that lead us into that improvement cycle, the PDSA, the Plan, Do, Study, Act cycle. That's a continuous cycle that then brings us back up to the questions. So again, a very iterative model. We know that quality improvement work is a continual process, a very dynamic process, and this model represents it really well. So as I just said, the model for improvement really does use three questions as a framework, and it's important to not skip over, to really focus on those questions. The model also encourages learning by testing change on a small scale, whether that's with one unit, with one physician, one shift, one part of a patient population. Doing small tests of change is a really great way to learn and to understand what we want to spread, what we need to refine, how we want to move forward. The model for improvement also helps us eliminate studying the problem to death, or as we're fond of calling it, analysis paralysis. It really moves the team or helps move the team from contemplation to action. Because it's a small test of change, it really also minimizes the data collection burden and data overload. You're collecting just enough data to know whether you're going in the right direction and then taking action based on that. And it works well with small numbers. So it's a model that works in large practices and small practices equally well. So Deming, one of the gurus of quality, says if you do not know how to ask the right question, you discover nothing. And that's really at the root or the basis of the three important questions that are part of the model for improvement. What are we trying to accomplish? How will we know change is an improvement? Because change can also go in the wrong direction. And what change can we make that will result in improvement? So let's talk about each of these. What are we trying to accomplish? Improvement, of course, begins with setting goals and really stating very clearly what it is you want to accomplish. It is important to gain agreement from the team, making the goal achievable, using a percentage or something that's measurable, because, again, you won't know if you've gotten where you want to be if you can't measure and know what your progress is. And it should be a stretch. So that's the tricky balance, making it both achievable but really a stretch because you want to be doing something differently in order to change the practice. So using our example that we're following through here, we've just focused in on diabetes and we've focused in on the African American patients. Our goal in this case is that we want 75% of our African American patients with diabetes to have their most recent blood pressure reading to be below this threshold of 130/80. Again, there's lots of different ways you could set that goal, but for our example here, we're going to focus on African Americans, diabetes, and blood pressure, and strive for a 75% achieving that threshold. So how will we know that change is an improvement? Again, this goes back to one of the foundations for quality improvement, that measurement allows us to determine if change has made something better or made something worse. We often use process measures, although more and more we're able to get to outcome measures in quality improvement work. Process measures measure an activity that's carried out to provide care or service. For example, African American patients with diabetes who have a blood pressure reading of greater than 130/80 will have a second blood pressure taken by their physician and follow-up documented in the medical record. That's a process measure. We're not saying anything about the level of the blood pressure reading. We're saying what the process is that we're going to assess. Distinct from an outcome measure that measures actually what the outcome is, what happens or does not happen as a result of what you've changed in the process. And so that would be then, for example, the percent of African American patients with diabetes who have a blood pressure of 130/80 or less. So the sample measure that we've declared here is an outcome measure. So then we ask ourselves, well, what changes can we make to achieve our goals? In this question, we're looking for ways that we can limit the variation in the process. How can we streamline or simplify? We are notorious in healthcare for adding and overloading our processes with additional steps and really never taking anything away. So asking ourselves this question about simplifying or streamlining is that opportunity to get back to understanding what really needs to be a part of a process and what are those extraneous steps that actually reduce our efficiency or impinge our ability to deliver the highest quality care. This is also a great opportunity to learn what has worked at other facilities, copy those, or a phrase we're fond of using, steal with zeal, and to recognize you don't need a perfect solution the first time. Again, these are small tests of change that are intended to be iterative. We're intended to learn from them and to test and to try things out. And again, this will help us from being paralyzed by the overwhelming sense that we need to come out of the chute having it done just right. So if we ask ourselves, what changes can we make to achieve our goal? Often this is the chance to clarify what's currently happening, what the current process is. This is a great opportunity to do some flow charting or process mapping at the actual process that's in place right now. Not what you want it to be, not what you hope for it to be, not what you wished it would be, but the reality of the way it is today. And that often points out to us things that are redundant. It points out the logic or illogic in terms of how the work flows. It might point out things that are forgotten but are really important to the work. It might point out where we are experiencing delays in our process or missed opportunities, and it allows us to look at the continuity of care across units or disciplines. And then we say, once we understand that current process and have done the flow chart or process map, what are the things we want to put in place? Is there some new guideline that we need to reach agreement on as we look at new clinical evidence? Is there a standard process, for example, for evaluating and managing patients that we want to put in place? It might look like standing orders or some sort of reminder system. Or do we need to want to change our process for patient education that might be tailored to specific populations? So again, that just kind of walks us through the model for improvement, again, as a grounding as we begin to think about using race, ethnicity, language, country of origin data to making quality improvement changes. So if we've asked ourselves the questions and done as a team the responses to those questions, then we're ready to move into the PDSA cycle, the Plan, Do, Study, Act cycle. And here we are looking at the plan, and we want to figure out, well, what change are we testing in this cycle? Who is included in the test, whether that's specific patient populations or subpopulations, or particular physicians or nurses or parts of the clinic or practice? When are we testing? What's the timeline? Is this just over a couple of days? We're going to do a quick test to change. Is this over a couple of weeks because that's what the time needed is to test the change? And where are we testing it? What is the actual action plan that we're doing? And I want to give you an example of a couple of things that have been done here in our community. In 2006, the Health Partners Medical Group began using patient race and language data to drive some of their quality improvement efforts to try to reduce disparities in care. So in one Health Partners clinic, they identified a gap between white women and African American women who received mammograms. that all-important cancer screening. So when they studied the issue and looked further into it and did some of their own process mapping, what they decided to focus on that was offering same-day screenings as a more effective way to increase mammography rates for African American women. So they did the test of change, they implemented the PDSA, they implemented it across the clinic, and with this change, the gap between the screening rates for white women and African American women decreased from what was at the start of the project a 16% gap down to 2%. Health Partners also developed customized scripts for talking with African American patients about the importance of colon cancer screening due to their increased risk of dying from the disease. And so because of these scripts and some of this planful way of how to engage with their patients as partners and being particularly attuned to the African American community, they planned to increase the amount of educational materials for patients based on their cultural values and health needs. So it revealed to them some additional work that they wanted to do in that area. Using our example, we might think through with an African American population and focusing on diabetes, is there some outreach that might be helpful that we could ask either one of our nurses or our diabetes educators to do specifically with our African American population? And we might make the distinction between our native-born African American population and this group, as we saw from this example clinic, that are coming from the Somali or Ethiopian background. Might we engage with someone who's from a faith community or from a community organization? Are there some community health workers or some parish nurses that we might engage with that could help us do outreach around, again, diabetes care, the D5, and in particular this blood pressure measure? Or do we want to form support groups that are specific for subsets of our African American community that are our patient population? And how would we then plan for those and make those into small tests of change so that we can measure and assess how effective any of those changes are or how effective they are as a package? Also part of planning is predicting. If you are laying out your plans for a small test of change, what do you think will happen? What do you expect? And then how do you develop your goals and your measures for assessing what's likely to occur? What data are we already collecting? What do we have available to us at our disposal to use as we are implementing the small test of change? What other data might we need? And how are we communicating with others? So if you have effectively, as a team, answered all of those questions, then you're ready for the do step of the Plan, Do, Study, Act cycle. And this is where you actually test the plan on a small scale. You're doing a pilot where you're implementing whatever change that it is that you've planned. You're collecting the data that's telling you what's happening as a result of that change, and you're making observations about the process and about the changes. How are you learning as you're going, as you are implementing it? Once you've made the change, this is the time to evaluate, to analyze the data, compare the data to what you thought and expected to occur, to your plan, to your goals, and really ask yourselves, what did we learn? What were the problems as we implemented this change? What were the successes? And were there any surprises? That's often the most revealing question, is to ask the team, well, what were the surprises as we put this change in place? And then to ask yourself, are we satisfied with the results? Did this achieve what we want or intended to? ACT then brings us back to how do we close the loop and really start the cycle again? What changes do we want to make before we put a new cycle in place? What did we learn from this test of change that can inform us as we go forward? What is the next test? And then how do we go through the whole planning cycle again? Or are we ready to implement more broadly? Did that give us enough information to say, it's time to spread this across? We're ready to do that. We're ready for a spread strategy. It's also important at this stage to ask, how will we maintain the gains? If we accomplished what we wanted and we achieved the results that we intended, how do we make sure we maintain it and it wasn't just a one-time effort because we were particularly focused now? So how do we embed the systems and the processes to make that work? And then establishing a new plan starting of the cycle again of the PDSA cycle. So we all know who have worked in quality improvement that it's not easy, that there's no off-the-shelf solution. Otherwise, we would have done that. We know it's hard work, and it often sometimes feels like an uphill battle, and according to this visual, maybe an uphill battle with no oxygen available to us. It's a steep and curvy path. There are often unexpected twists and turns as we are trying to improve the quality of care that we deliver. But what we also know is that as we continue to get smarter and more sophisticated, and as we continue to take advantage of new data sources that are available to us, we're much smarter about this work. We're much more patient-centered about this work, and we can really make both incremental and big leaps in our quality of care. And the race, ethnicity, language, country of origin, insurance data that we will soon have available to us is a terrific addition to the whole set of data that's at our disposal as we continually evaluate and improve the quality of care that we deliver, and we try to be more and more responsive to our patient populations and our changing communities. So I'm going to stop there, wanting to make sure we leave ample time for question and dialogue. Ryan, if you would open up the lines, we'd welcome some questions. We'd welcome from those of you who are on the line sharing any examples of using race, ethnicity, language, or other data to do quality improvement work to try to reduce or understand the different cultural communities that we're serving. So with questions or with examples, Ryan, will you open the lines?
Certainly. The floor is now open for questions. If you do have a question, please press the number 7 or letter Q on your telephone keypad. Questions will be taken in the order they were received. If at any point your question has been answered, you may remove yourself from the queue by pressing 7 or Q again. If you are using a speakerphone, we ask that while posing your question, you pick up your handset to provide favorable sound quality. Please hold while we wait for the first question.
Great, thank you. While we're waiting, I will again reiterate the website information that I stated earlier because it wasn't on our slides anywhere. If you go to www.mncm.org and you click on the resources bar, what you will find there is the handbook on the collection of race, ethnicity, language data in medical groups that was developed by Minnesota Community Measurement, adapted from a national toolkit that was available. You will also find the companion recorded webinar and slides from the session that goes along with this one that is focused on the collection of data. So hopefully the pair of those, the collection of the data and then how to use that in quality improvement efforts, give you a really solid starting point for what either you currently have or soon will have available to you at your clinic. So Ryan, are there questions or comments in queue?
Could they hit 7 or Q again? The conference was not set at that moment in time when I had said for questions. So if you did it, hit 7 or Q, please hit 7 or Q again. The conference is now set to allow questions.
So this is Jennifer. I can see the list of participants on here, and there are many familiar names to me. And so I know that many of you have done quality improvement work that has been related to race, ethnicity, language, country of origin. And again, I think this would be a great time to share some of your lessons learned, some of your challenges, some of your barriers, any advice you have for the group. So please do feel free to share either questions or examples and some of your past experiences.
The first question comes from Missy Voigt. Please state your question.
Hi, this is Kathy Miller from St. Joseph's Medical Center in Brainerd, Minnesota.
Hey, hi, Kathy.
How are you?
Good, thanks.
My question is, could you talk just a little bit more about the requirement to report our data that will become effective in 2011?
Sure. I can talk about that, and then I know I have some colleagues on from Minnesota Community Measurements, and they might want to chime in as well, but let me take a stab at it. And I'm going to see if I can scroll back to the slide where that information was contained. So if you'll just bear with me for a second, I'm going to try to get back to that one so that it's up on the screen for us as well. Sorry. It's taking me longer to get back there than I thought. Okay, here it is. So for clinics and medical groups that are currently participating in the direct data submission process for Minnesota Community Measurement, and that's certainly the majority of large practices and medical groups across the state and a growing number of smaller clinics and practices, starting in 2010, so starting next year, there will be a voluntary expectation. Does that work together? Voluntary expectation. There's a hope that you would start collecting race, ethnicity, country of origin, and insurance coverage data and submit that as part of your submission in direct data submission. So that would be in 2010, and because it's a retrospective look back for data collection, it would be for dates of service that are happening right now in 2009. But because we're just doing the training now, because the handbook's just been released, that's not a requirement. We know most places aren't collecting these type of data quite yet, so this is really the kind of getting started year. And those data would then be reported on the community measurement website, particularly linked to depression, diabetes, and vascular care. But starting in 2011, and then that would be for 2010 dates of service, starting in 2011, for anyone that is participating in the direct data submission process for Minnesota Community Measurement, it will be a requirement that you are also submitting REL, country of origin, and insurance data that you have collected as part of collecting the clinical measures. So in 2011, that will become a requirement for those participating in the direct data submission process, and that will cover 2010 dates of service. What's also going on, as many of you know here in Minnesota, is the health reform initiatives and mandates that our state legislature passed in 2008. One of those is the development of a new quality measurement and payment incentive system here in Minnesota. And while the draft public rules that are out for comment right now do not indicate the requirement for race, ethnicity, and language data collection, what we know is that that's been a fairly prominent part of the discussions. And so this is now Jennifer speculating, I would speculate that REL data, country of origin, insurance coverage, may well also become part of what the Minnesota system is by state mandate. And because Minnesota Community Measurement is going to be the designated data collection repository and system, those two things would then go hand in hand. So that was a really long answer. Did that get at what you were trying to?
That was very helpful. Thank you so much, Jennifer.
Good, thanks. And let me ask Nate or others, if you're on from Community Measurement, if there's anything that you would like to add to that.
Can you hear me?
Yep, you're on.
Okay, yeah. So I also want to emphasize more too that we understand that this is certainly a process for groups, and part of this communication plan with the webinars and with the handbook was to really get the information out there to people that our direct data submission will be in the future requiring this, but we understand that it's not an easy process change for groups, and so that's why we thank Stratis Health for their support and teaching the quality improvement process along with this. So we certainly understand that it's not just a click of a button to begin collecting and reporting this data, and from Minnesota Community Measurement's perspective, it's it's going to be a trial run for us too to see how the data comes through the first year, to see what different breakdowns we have of data and how, in terms of validation, how reliable the data is. So this is a test phase for us as well, and we appreciate people's patience and willingness to try it this first year.
Thank you, Nate. And I think that that's a good way to frame it up. We're really learning together how to do this well, and I think that the experience that some groups and practices have had can really be great learning for those that might be just starting out. But really, this is a journey that we're all on together because we do this sort of data collection fairly poorly across the country. There are not a whole lot of models out there. We know a lot of population and public health data, but we really do not, at a practice level, at a hospital level, at a medical group level, know very much about the differences among the subpopulations that are different cultural communities. And again, in Minnesota, we have a rapidly changing patient population. Our demographics are shifting. We have a lot of immigrant and refugees coming to our community, and our ability to serve them well, to be culturally aware and culturally competent as we deliver care, and to be able to use the tried and true quality improvement practices that all of you have been working on for years and now bring to bear the race, ethnicity, language data into that process will be really important because of who we're serving and that ever-changing community and population. Ryan, other questions in queue or comments?
Again, if you do have a question, please press 7 or Q on your telephone keypad. It appears we have no further questions.
All right. Well, then we will bring this session today to a close. Again, I encourage you to continue to take advantage of the resources that are available on the Community Measurement website, both the handbook and the materials from today's session, as well as from the companion session that's about the data collection piece of this. Again, we're on this journey together to try to improve our ability to understand the patients that we are serving and the communities that we're serving, and we look forward to your active participation as we move forward in this. So thank you for your time and your work.